My name is Sarah. I'm with the Shelter Island Public Library, and I am here with Karen Wolfrott and Dr. Louisette Soussan to discuss kidney health. First off, I'd just love to thank our East End libraries for participating. Thank you to Amagansett, Cutchogue, Quogue, East Hampton, Port Jefferson, Mattituck Laurel, Hampton Bays, Southold, and West Hampton Free Library. And with that, just as a reminder, if you have any questions, please leave them in the chat throughout, and we'll get to them during the Q&A portion of the presentation. And with that, I'm going to turn it over to Karen Wolfrat. Thank you.
Thank you, Sarah, and thank you for hosting this month's Zoom library partnership with the Stony Brook Southampton Hospital and the Suffolk County Library Programmers. This is a program we've been doing since COVID, and it's been very successful. And we're really happy to be here this month with another program. So I'm going to introduce Dr. Louisette Soussan. She attended medical school at Ben Gurion Medical School for International Health in Israel. Her residency in general medicine was completed at New York's Mount Sinai Icahn School of Medicine, followed by a fellowship in nephrology at Hanuman University Hospital, which is a part of Drexel University College of Medicine. She is fellowship trained nephrologist specializing in the comprehensive evaluation and management of acute and chronic kidney disease. Her clinical expertise includes complex hypertension, fluid and electrolyte disorders, mineral metabolism abnormalities, and the management of advanced kidney disease, including dialysis care. Her background includes experience as an internist, which provides her with a strong foundation in adult medicine and a broad understanding of the multi-system conditions that frequently accompany renal disease. Dr. Soussan is board certified in internal medicine and nephrology. She's also a certified hypertension specialist, reflecting advanced expertise in the diagnosis and management of resistant and secondary hypertension. She sees patients at Stony Brook Southampton Hospital's Meeting House Lane Medical Practice offices in West Hampton, Hampton Bays, and in Southampton. And welcome, Dr. Soussan, and thank you very much for doing this talk this month.
Hello, everyone. Good afternoon. Thank you for the kind introduction, both from Sarah from the library and Karen. Thank you so much. It's a pleasure to be with you this afternoon. And yes, I just wanted to give a general, talk about kidney health. And please, if you have questions throughout the talk, you could post them in the chat, and we'll definitely have ample time at the end to, go over questions. Can everybody see my presentation? All good in my screen?
Yep, looks good.
Yeah. Okay, thank you. So today will be just a general talk, about kidney health. Okay, so first starting, with very basic, I'm a nephrologist. What is nephrology? So nephrology is the branch of medicine that is concerned, with the study and treatment of disorders and disease of the kidneys. Okay, so what are some facts, about kidneys? So as you can see, in this, picture, we have two bean-shaped, organs that are located just below the rib cage, around like the low back area. I say most people have two kidneys, each the size, of a fist. And I say most people because some people could be born with either, horseshoe kidney or a very small kidney, or some injury that happened, very young in age that resulted in, just having one kidney. But most people have two, each, one on the right and one on the left side. The two kidneys are then connected to, the two ureters that lead to the bladder and out, to the urethra. What are some facts, just about kidneys? So each kidney, contains millions of tiny structures called nephrons. And the nephrons, they act as individual filters, and they work continuously 24/7 to perform, several important functions in the body. Just a fun fact, about the kidneys, they can filter roughly around 200 quarts of fluid daily. It is, a lot for, those small bean-shaped, organs. So what do the kidneys do? So the kidneys, their main their main function is to remove waste product in the body. They filter toxins out of your bloodstream. So how does it do that? So when blood enters the kidney through an artery from the heart, right? So the blood first enters the kidney, then the blood is cleaned through all those filters that I was talking about, those nephrons. They pass through about 1 million tiny blood filters. Then after they pass through those filters, then you get these waste materials that gets passed from the kidneys, as you see here, down to the ureters on both sides and into the bladder. And the bladder is basically going to be the waste, material that gets collected until it gets passed, through the urethra to the, the urine that we make. Now, after the blood is cleaned and the waste, gets into like the bladder, the rest of the blood gets back, it gets cleaned and returned back to the heart and to the bloodstream, via the veins. And of course, like I said, after the bladder becomes full, that's how the urine passes out of the body through the urethra. So this is what like the main function of the kidney. It really filters, cleans the blood, takes away the toxins, and returns you, clean blood, to your bloodstream. But that's not the only thing they do. This is their major function. But by doing so and by doing their filtration system, it also balances the fluid. It helps, they help like regulate water, sodium levels. The kidneys are in control, blood pressure by releasing hormones that manage your blood pressure as well. They also help keep your bones healthy by activated vitamin D to keep the bones strong. They also help balance minerals in the body, and they also help make red blood cells. All this is important because if the kidneys don't function as well, all this can get affected. It's not just the filtering system, but the bone health we watch, all the electrolytes imbalance, the red blood cells, so that can lead to anemia. So the kidneys really have like a wide variety of roles, mostly like I said, the filtering system, but also everything else to help keep everything in balance. So now what happens when, what is chronic kidney disease? So what happens? So what happens is that when your kidneys are losing their ability to filter blood, or do the other jobs I mentioned well enough, to keep you healthy, that's what is called, chronic kidney disease, otherwise known, as CKD. You often, hear that word. So how prevalent, is, chronic kidney disease? So more than 1 in 10, so 14% of US adults, about 37 million people in the US are estimated to have chronic kidney disease. And this is like data from the CDC. Now, what is shocking is that more than 1 in 10 have that, is that 9 out of 10 patients, 87% of adults, do not even know they have chronic kidney disease. So then we go, if you're not even aware that you have chronic kidney disease, what can cause it, or how do you even know, you have chronic kidney disease? So there are different risk factors, right, for chronic kidney disease. First, you can have, like a primary medical condition, that can lead to chronic kidney disease. And the leading cause of chronic kidney disease in the US is diabetes. About 4 patients, in diabetes, out of 10, 4 out of 10, so about 38% of adults with diabetes are estimated to have chronic kidney disease. The second, leading cause of chronic kidney disease is hypertension, otherwise known as high blood pressure. About 2 in 10, so 21% of adults with high blood pressure are estimated to have chronic kidney disease. Another common reason for kidney disease is heart disease, heart failure. As you all see, those are not primary kidney disease, meaning your kidneys were born, healthy, they were normal, but it's other medical conditions, mostly like diabetes and blood pressure. So this is like a secondary process that lead to kidney disease. So how does it do that? So when you have, for instance, diabetes, right, you have high blood sugar. So the high blood sugar, it damages the kidneys, microfilters over time, right? Like all those filters that I was talking about, it can damage that. It can, when you damage the filter, when you have all the toxins that come out, it can contain, like good things like your protein, because the filters are damaged. So like protein can start, spilling, into the urine, but those are good protein. Those are proteins, from your body. So that's the main mechanism of how diabetes, damages the kidneys, over time. Now, what about high blood pressure? Really close second after diabetes. So when you have high pressures, right, the pressures come straight, from the heart, to the kidney. It just puts too much strain. Like you think about it, all the blood vessels that carry, all the blood, to the kidneys. When the pressure is so high, it's just so much strain on the blood vessel. So it damages, your vascular system. And heart disease, similarly, heart failure similarly, because when you have a reduced function of the heart, there's reduced pump function. So if the heart is not getting well perfused, the same will go with the kidneys. And like I said, all these are risk factors, primary medical conditions that really need, I cannot overemphasize, they need to be treated to prevent not only chronic kidney disease to develop, but to prevent the worsening of kidney function. Now, of course, other than primary medical conditions, right, that you develop in your life, there is also lifestyle and environmental factors. So certain medications, and there's a long list of medications that could be toxic to the kidneys, but I really want to focus on one, because this is a very commonly common medication found over the counters that most people have used at least once in their life. And this is the category of NSAIDs, which is the non-steroidal anti-inflammatory medications, such as ibuprofen, Advil, Motrin, Aleve. All of the medications could have a toxic effect on the long run. I would say not on the short term, if you had a good reason, to be on, ibuprofen for a few days because, you sprained an ankle, then that's, reasonable. But the chronic use for just, for pain management, generally, the chronic use of, anti-inflammatory medications can also lead, to damage to the kidneys. Smoking as well, going along, with the high blood pressure, the smoking really will affect, your overall like blood vessel health. It will cause more like narrowing of the blood vessels and can worsen, kidney damage. Another, lifestyle and environmental factor would be, like obesity, because just, in general, like carrying, excess weight can really place and increase, like strain, like a metabolic strain on the kidneys. And also in and by itself, it can elevate the likelihood of developing, diabetes and hypertension. Now, sorry, I went backwards. So what other can cause? So then we also have, non-modifiable demographic factors. So these are the things, a family history, having like a close relative, like a parent, sibling, or grandparent, with kidney disease or kidney failure, depending on the etiology of it, can also increase your risk, your personal, risk of kidney. You could have any like congenital, you could be born, like I mentioned in the beginning of the presentation, with like one small kidney, for example, or, like an abnormal kidney that could be just, from birth. Other things that can cause, kidney disease, any like autoimmune disease can also affect that. Getting older, right? So kidney function like naturally, gradually declines, as the body ages. So, anywhere above the age of 60, will increase, your risk, of chronic kidney disease. I also mentioned, like race, and ethnicity. So, statistically, I would say individuals, like African American, Hispanic, Native American, will definitely face a higher risk. Really largely, I would say attributed to higher rates, of diabetes and hypertension as well. So, right. So when we talk about kidney disease, there's certain risk factor, that you really can't do anything if you are born with a certain disease or you have an autoimmune disease. That's, primarily, but that really is a smaller percentage. We definitely do see a lot, of people with this disease, but this is, less compared to the other, lifestyle, environmental factors and primary medical conditions. So what I'm trying to lead at is that when you have, kidney disease, if you have a primary kidney disease, that, can be treated. But other than that, the management will focus on risk factors. What are the risks? What is causing the kidney disease? And how can you maintain your chronic health to help prevent, not only the formation of chronic kidney disease, but also the progression of it. So yes, I talked about all the, like risk factor. Now, the other things to know about chronic kidney disease is that it is a very silent disease. You will not know. You could live a normal life. You will not know that you have chronic kidney disease really up until 80 to 90% loss of kidney function. The kidneys can take on a lot of stress. They can have a reduced function all the way down to 20% before you would even know, if I go by symptoms alone, that you have kidney disease. Hence why 1 in 7 adults have CKD, and most people don't even know it. I was saying more like the 90% don't even know unless we do screening test for it. So, right, and then subtle signs. So certain signs that, you will find about chronic kidney disease are very, very non-specific. It goes with fatigue, feeling unusually tired, having trouble concentrating. But as you can imagine, this is a very common, symptom that can be associated with a number of disease and definitely not, specific, to kidneys in general. Other signs, subtle signs that you can, look for would be swelling, typically retention of fluids, in the ankles, in the feet, in the hands. And that typically happens, when there is protein leakage, in the urine that makes you, having more retention, of fluids. Eating more salt will also lead, to more swelling, in your lower extremities typically. Certain signs, again, very subtle, you would notice some change in urination, maybe some foamy urine, urinating more frequently at night. Like I said, those signs are very non-specific and often happen when you are later on, in the chronic kidney disease. So then, all that being said, how do we diagnose it? So how do we know, we have chronic kidney disease? So typically, kidney disease is diagnosed through blood test and urine test. So blood test, you often hear about the serum, creatinine, and also we talk about the eGFR, which I will go in detail in the next slide. Urine test, typically we test, the main thing is the urine albumin, which is the main protein in your body. And we do this ratio of the albumin to the creatinine ratio. We also use, ultrasound or other imaging tests, just to look how, mechanically, how the kidneys, look. Do they look healthy, normal size? Is there a blockage? Is there a stone in it? Is there anything that's affecting, just, on the appearance, of the kidneys? And of course, if we really, after all that, have, based on history, test, urine, ultrasound, and we still can't figure out why is there, a kidney problem. Like I said, it could be a primary, autoimmune problem, vasculitis, lupus, a lot of, autoimmune disease. Then if we can diagnose it with all the above, then we do have to do a kidney biopsy to help diagnose. So I want to focus on the GFR, because this is really the, sort of our basic test. And eGFR, so E stands for estimated, and GFR is the glomerular filtration rate, right? So it basically measures your filtering speed. I almost think of it as what is your percentage, of kidney? How much can it filter? right? Ideally, normal, you should be 100, even up to like 100, 90, above 90 to 120 is considered normal. So I think of it like 100 as being, normal. It also could mean if you're between 90 to 100, you could have very, very, very mild, kidney disease, what we call like a stage 1, very, very early on. And that's not based on the GFR itself. It's based if you're having like protein leak in the urine. So we'll go over how it's not just the blood test, but we use the blood and the urine test, together to make the diagnosis. But typically you think of like a normal, around like 90, 100%. Early stage, most people don't even come to see me when they're between 60 to 90%. If you look at, one of your blood work results, you will probably notice when it's above 60, it typically would say EGFR, greater than 60, it won't even get picked up as, flagged as abnormal, because it's maybe a stage 2, very early stages. But it's the beginning of it, so it's good to know where you're at, what we call establish like a baseline. Most people, of course, the kidney disease is anywhere from less than 60%. So then we have different stages to call it by. So kidney disease between 15 to 60%, and really less than 15, I would say this is the more advanced kidney failure. So this is from like the National Kidney Foundation, excellent, I would say resource for, patients just in general to navigate and understand, kidney health. Lots of resources on, like nutrition, on, management of blood pressure, just general information on kidneys. So this is, one of their slides that I took just to describe this. So this is how your kidney functions. So when you have normal kidney function, maybe a little bit of protein in the urine, this is what we call normal, when the GFR is 90 to 100. A mild loss of kidney function, I would say if you're more at risk of kidney disease, this is when you are between 60 to 90%, also known as a stage 2. Most people that I start seeing are here in the mild to moderate or moderate to severe. So they split it out because initially we had it between 30 to 60%, but then we noticed people would, behave differently when they were, 45 to 60%, which is, better than being, 30 to 44%. And 30 to 44 is already a moderate loss. So you will see like a stage 3A and a 3B for here. Stage 4 is a more severe loss, 15 to 30%. And again, you can still continue to live, normal, up until, usually like around like the 20th percentile. When you reach, less than 15, really, this is where, the kidneys, they just can't assume, the job of it. It's just not enough. And the kidneys, at that point, are, failing when it's, less than 15. And our goal is, to target, patients really in that stage, the mild to moderate, moderate to severe. This is the stage 3, you're right in the middle, and we try to keep you, in this stage the longest, possible. Yeah, certain people can stay years, in CKD stage 3 without, progressing, to kidney failures, and other will advance, more rapidly, depending, on the etiology of the kidney disease. The other test, so this is a simple, really blood work. Most blood work, you would see like a metabolic panel, a chemistry panel, will give you, your GFR and the creatinine. I focused more on the GFR as opposed to creatinine itself, because the creatinine can really vary based on age. It can be, based on muscle mass. People taking, like, for example, like creatine supplement, it can, show that the creatinine, would be like higher when you don't really have, a kidney problem. So the GFR is really like it's a good measure of like a filtration rate. And we have newer markers now that we can use, not just creatinine, but like independent of creatinine, to help assess. Always the big question is like, how do we truly assess, the filtration rate at any given time? But it's a quick, easy, commercially available, any basic test, you will see the GFR, resulted. The other tests that, we do, of course, we do many more tests, but those are like, I would say, really, if I had to focus on like 2 tests, would be the GFR and then the urine albumin. test. So it's a urine albumin. It's a protein that leaks when the kidneys are damaged. So remember I was talking about those, filters. So those filters are, our nephrons. They're very tight. They don't let anything go through except for waste product, small particles that get, toxins that, those are basically our waste removal. But albumin is a large protein. Protein are big in general. They should not be able to go through the filters of the kidney, like ever. Like normal should be less than 30 milligrams. You should not have any, like protein. So when we start having like leakage of protein, typically it will often be the very, very first sign, the very beginning of chronic kidney disease. You see that like years, before any symptoms, would appear. So like I said, normal should be like less than 30 milligram, really like nothing. Moderately increased, 30 to 300. Most common cause of having albumin in the urine, I would say by far would be diabetes. That's literally how the diabetes damage the kidney, by spilling, leaking, your protein into the urine. And then severely increases when you have more than 300 milligram. So why do we care, about like the exact, like number? Because we have what we call, this like heat map, right? So here, the way that we think about, kidney disease is we look at the GFR. So G is for G stage 1, stage 2, stage 3, 4, 5. And then we have, the albumin on the other end. So ideally, you want to be in the green, right? Minimal protein, no protein in the urine, and working, more than 90, 60 to 80%. And as you see in the yellow is when the GFR starts decreasing and you have more protein. And of course, on the red one would be less GFR and a lot more protein. So that's the worst. And the goal is to try to keep, green, yellow, slightly orange, but, try to avoid, the red, like area. So, well, how do we do that? How can we prevent that from happening? So, right. So the goal really, like if there's anything that I would say take home message, really for this whole talk is to be aware, of the risk factors, for chronic kidney disease, and really to promote, how can we prevent? What are the lifestyle habits? Unfortunately, with chronic kidney disease, of course, I'm excluding all the primary kidneys, people that are born with certain kidney problem. Autoimmune disease, that. But like I said, the vast majority, are very like modifiable, risk factors. So how can we, prevent that? And really the main things, you could do for, maintenance. So I would say if I had to like say 5 points, to talk about, prevention and maintenance, of kidney health would be number one, like staying hydrated, right? Kidneys, they do need, water, drinking water, consistently. You also don't want to overdo it, typically drinking, when you're thirsty, average, like 64 ounces, of like fluid a day. Again, I can't make that as a general statement that hydration is, the only key, because people with heart failure like can't even, drink, as much. People with other electrolyte abnormalities can drink as much. So, but most in general, we think about like hydration as like a good, good things, for the kidneys. Number two, eat, clean. And by that, we mean, really reducing, processed foods and heavy, sodium intake. 3 would be, moving daily, aiming, for, like exercise as much, like 30 minutes, of moderate exercise, a couple times a week, however often, is possible. Another prevention methods, as I was mentioning, earlier, is limiting, like for example, using like the anti-inflammatory, like ibuprofen, Aleve, Advil. So that's something that you can, one step, to help, prevent that. And then, quit, like smoking. Smoking slows, like blood flow to the vital organs. And really, like I often get asked, like what should the diet be like? In general, I would say, like lower sodium, but sodium is everywhere. We do need salt to live, but salt is found literally in everything. we do need, at least, 2000, 2300 milligram of salt, in a day. But that adds up pretty fast. 2300, when we talk about low sodium diet, it's really the equivalent of 1 teaspoon of salt. So that adds up, pretty fast. So thinking about, like processed food, chips, pickles, deli meats, all these are like conserved, in like salt. So really, like the amount of salt can really like increase, just even when we think we're not using like the salt shaker, like salt is everywhere. So just to be mindful, of our, like sodium intake. A key is like, trying to read, food labels, using, different herbs and spices, instead of table salt. Not easy, but definitely a healthy thing to start, early on. So, what is the plan of care? So as you see, the main thing, like I said, is to try to decrease the modifiable risk factor, like keeping blood pressure controlled, keeping the blood sugar, control. I know easier said than done, but this is really, really key into prevention, of kidney disease, lowering the cholesterol, managing, like the anemia, the bone problems that can, happen with chronic kidney disease, prevent like or manage, like malnutrition. Right. But we also have, medication that help, prevent and, the progression of kidney disease. So you'd often hear people saying, oh, I take like an ACE inhibitor, something like lisinopril, or I take like an ARB, something like losartan, or in that family of, medication. So typically they help blood pressure. They also help reduce the amount of protein in the urine, which is key. Newer medications, you'll often hear like SGLT2 inhibitor, something like, you hear commercially like Jardiance, Farxiga. They help really reduce as well, the amount of protein in the urine. If you get more advanced, kidney issues, then if there's, retention, you often need to, be on like, diuretic or like water pill to help get rid of, the excess fluid. But of course, this is like very generalized. Each treatment is based, individually. So then, let's say after all of this, what happens, if the kidneys, stop, completely, So that's when we call it, end-stage kidney disease. And that's, we work, really hard to help prevent, getting, to that stage. So how do we do that? Like medical management, right? Like, trying all what we just talked the whole, presentation about. But if really kidneys, fail completely, then we have, other, kidney transplant would be, a next step, into that. That would be the ideal, the gold standard, of treatment of kidney disease. But unfortunately, not everybody is able, to get a kidney transplant. Then we have, dialysis, modalities. So this is where, probably one of the only organs that you can, survive, with them, being failed. If the heart doesn't work, the lungs, you can't leave. But with the kidneys, we do have, I mean, not that it's ideal, like situation, but we do have, modalities to help. So like dialysis, for example, this is where like the machine basically takes the job over, of the kidneys. It goes, so basically all your blood gets pumped into this machine, filters it, you literally have like a narrow, long filter that will clean, the blood and returns it to your body. The problem is that, it's, the kidneys used to work 24/7, and here we're trying to do that, 3 days a week, at least, for 3-4 hours at a time, right? So but that's really you can also have some other modalities like dialysis, like that you can do, like at home, but again, that would be very specific and discussed, with your kidney specialist. So that brings me into, like when do you see, when do you need to see a nephrologist, right? So typically I see, a lot of people with chronic kidney disease. And when we call chronic, it means it's at least 3 months. It's a gradual loss of kidney function, over time. But, we often also see people for acute kidney injury, something that's, either in the hospital or outpatient, when people just have a sudden temporary, failure of the kidney. And hopefully, that could be reversible. Nephrology, other than just, kidney disease, we also deal with a lot of electrolyte abnormalities, because remember, one of the function, of the kidneys are to help like sodium and water balance. So we could see a lot of, low sodium called hyponatremia, electrolyte abnormality, low potassium, low calcium, low magnesium, because all these electrolytes are balanced, in the kidneys, and they go through similar, like filtration system. And kidney stones, right? So that's another thing, right? Kidney stones, that's also another big things that we follow up. And finally, like one thing that not a lot of people realize, that really the blood pressure is really managed, and like the hormones through the kidneys. So I would say one of the big portion of our time we spend is hypertension. Particularly, I have a big interest in like hypertension, and because the way that it affects, like blood vessels, like in general, and, in the kidneys. And so, yes, I would say really like for high blood pressure, working along, with your primary care, physician, as well as, nephrology. Sometimes I see people with no kidney problem, just with like high blood pressure, especially when it's resistant, requiring, multiple, like medications to get to that. And so right, so that's when to see, and like, what to expect. So what do we do, like during, an initial visit, when you come see, like a nephrology. Of course, we go to significant amount of time, going over the medical history, right? All the risk factors, all the things I mentioned, during, this presentation. I say like focused exam, mostly on the like swelling, heart and lungs. We go over like extensively on like medication, right? Anything like over the counter, supplements, prescribed medication. A lot of medication need to be adjusted, for the reduction, in kidney function. We review, the blood work. When we see like an abnormal GFR, is it just happened like today? It just happened in this recent blood work, or has it been like that for the last couple of years? So it's good to establish, what is, the baseline, over time. And we also, we at the end of the visit, mostly we'll be ordering the blood work, a lot more than just like the GFR. But this is, I just gave you like a few of the tests that we would do. But yeah, blood work, urine test, right? We often also order like imaging of the kidneys. We want to make sure that they're just mechanically they're looking okay. That you have two kidneys, no blockages, right? Sometimes you could have kidney stones, obstruction, to the kidneys. And then, during the nephrology visit, come up with a treatment plan. Like I said, mostly it's going to be all about, right? There's certain factors that we can't, change, the way, we're born, family history. But then most of it, a lot of it is lifestyle as well. So we definitely, discuss, that. Medications, like I, mentioned, unfortunately, in kidney disease, there is no one medication that can help, reverse kidney disease. Kidney disease is a progressive disease, and the goal is really to keep to slow down the progression, as much as possible. So that's why I was mentioning certain medication that can help do that. So yeah, it's a very like individualized treatment plan for that. And yeah, so right, so like good, like well, those are the reference I use, for like my presentation. But I highly like encourage to look at the National Kidney Foundation. They have great resources of like just education, material on it. I also got some information from the CDC regarding like the prevalence, slides up to date, which is our website that has a different, more up-to-date, guidelines in, kidney disease as well, and just in general. Yes, I think that's what I have for today. Please, I know we have like a lot of times, for questions, and yeah, so we'll go over that. And I really want to thank you, for spending this time with me today. And hopefully you'll get some, good information and resource. And yes, and we're here to help.
Thank you, Dr. Soussan. We do have a few more questions in the chat.
Okay.
The first one is needing a more thorough understanding of autoimmune diseases.
Say that again.
needing a more thorough understanding of autoimmune diseases, and I'm guessing how it affects the
Right,
kidney
right,
function.
right. No, that's a very good point, and it's true. I did not focus, on that because that's more, like individualized. But yes, one of the causes, of kidney disease could be, like autoimmune disease, like lupus, being, a big one, causing like lupus nephritis, vasculitis, in general. And typically, we work along, with rheumatology. So that's another thing that I did not, talk about, in this talk is that, nephrology, we work, right, very closely, of course, with primary care, very closely with endocrinology because, like what all the causes I mentioned, rheumatology for like autoimmune disease, right? So like things like, for example, like lupus, require like a kidney biopsy for diagnosis, and the treatment. While a lot of medication that I mentioned, in this talk, still will apply there, it is very specific because you have to, use more immunotherapy for it, and things like prednisone, steroids, and much more intense treatment for that.
That's good. We had another one. Sometimes or some days one wants to eat or they kind of crave salty food like chips. Is that because you need more sodium, as in there's not enough in your diet, or is that actually unrelated?
No, that's a good point. Yes, it's true. That we often do have these salt. I would say living in the Western world, like living right here, like in the US, I would say very rarely do we not get enough sodium in diet. I think even when you buy like raw like chicken or raw anything, it still has like sodium in it. I think like very few people would really lack. Now, there is certain conditions like having like hyponatremia, like low sodium, you may be, craving, more salt, but it's really that you have, like too much fluid on you. Sometimes you could be craving salt if like blood pressure is low. So that's a natural, response because if you think about it, when you're like have low blood pressure or, you're feeling dizzy or lightheaded, your body's craving, the salt because that helps, raise your pressure. Uh, yeah, so that's what I would say about that.
Okay. I've read sea salt is not the same as sodium table salt, so the 2,300 milligrams a day does not apply. Is that true?
No, I mean, I would say yes, maybe like sea salt, is a little better, but it's still, I wouldn't say like it doesn't apply because I would say it's still, considered, like, sodium in general. And really for kidney protection and for blood pressure protection, you really want to decrease, like the sodium intake. And like I said, I really cannot emphasize if you spend, one day and charting what you're eating, you will notice just if you want to just try to do that, you will see how much sodium is in everything, that we consume. Yes, I would say probably like sea salt, is better, than just like table salt but it's still salt in general. And we do need salt. Don't get me wrong. Like we do need salt, but I feel like we are getting enough salt from just a regular diet.
Okay. We have another one, which is a comment and a question. We as patients are now more than ever having to remind doctors of labs and tests that we're looking to have monitored. It seems like we can no longer easily see specialty doctors without waiting months for an appointment. What advice can you give patients to be more proactive?
Right. So I think like it also, yes, no, that is a good point, right? So I mean, the key, I would say, the most important, I would say doctor really to have is a really, really good primary care because primary care would be the first doctor, right? Like if you're diabetic, for example, the first screening test, that they would do, they, annually would be like a urine albumin test and like a GFR. So that's first how it, it gets picked up. Primary care as well, often start, certain of these treatment that I mentioned. And I would say if there is, serious concern, to, right, like to try. I mean, I know you said like sometimes it takes months. Hopefully, I know maybe, yes, I don't know if all the specialties, the same way, but I would say really is going to be working with your primary care doctor to try to get into, to see like a specialist. But remember also, like, at least for the point of like, nephrology, this is a very like progressive, like over time. If something was very, acute, like injury, it, typically could be, seen, like in the hospital, or like that's more, urgent. And there's also, difference between like urgent consults and which, usually are seen, much sooner. I know that sometimes we can see patients within like, the same, week for urgent matters. But yes, no, this is definitely, access to like healthcare, in general is definitely, yes, definitely a problem.
Yeah, it's okay. I've got, did both kidneys fail together?
No, that's a very, very good question. Yeah, so I often get asked. So right, so yeah, that's something I didn't mention, in my talk. So typically, right, both kidneys work together, and they both provide, kidney function. We don't measure, how much kidneys contribute, but we assume it's about 50-50, right? They both work, together. Unless, you're either born with one kidney, or one kidney, had an obstruction, a blockage that made one kidney smaller, so then the other kidney will assume, function. But yes, typically when they fail, yes, it is, together. But that also brings me to like another point. That one person also could live with one kidney. That's something we didn't talk. Like people that, for example, like donate, a kidney, or people that are born, with one kidney could still live, a relatively, like a normal life. And I say relatively because you need to be more cautious about, all the other risk factors to help, protect, that one, kidney. But when you only have one kidney, it will grow larger and you will adapt to the loss of the other kidney for whichever reason, whether it's because you donated it, or because you were born with one kidney, or because something happened to the other kidneys. But all that aside, when you have two kidneys, when we say your kidney is like 40%, we assume that both of them are reduced at the same time.
Gotcha. Okay. What labs should be done and how often? Should it be once a year or twice a year? It looks like they're kind of looking for a guide for patients on just which labs should be monitored and how
Right. So
frequently.
right. Okay. Yeah. So it's hard to answer, to say once a year, twice. So it depends, right? Like for example, if you're diabetic, I would say at least once a year you should have your urine, albumin, check, and at least once a year your kidney function. But it also depends if that result come back that your kidney is in the 50th percentile and you have a lot of protein, then maybe it should be monitored, every 3-4 months, and and more often. And this is maybe when you need to start, like seeing, like a nephrologist. So it really depends on what. Like if you had normal, like right now you had no medical problem and you get general blood work and your kidney is normal, you don't even have, most of people wouldn't even have like a screening test, for urine. It's not, there's no like generalized, screening for getting like urine tests checked or blood work checked. Unless like it depends on like other medical conditions and risk factors for it.
Gotcha. Someone is asking about a diet for stage 3 kidney disease.
Right. Yeah. So stage 3, which is the most common stage, right? There's 3A, 3B, 45 to 60% or 30 to 45%. And this is what we target. This is the time really to make. So the diet, I don't know. I think I cannot emphasize more, like lower sodium, lower sodium. Sometimes you often refer that as a DASH, diet. Um, something like I would say a good diet for like stage 3, I would say a Mediterranean type of diet. When you think about, Mediterranean, diet, you would see, half the plate with like fresh, like salads, fresh vegetables in general, lean protein, and like, a quarter of like protein, quarter carbs, and then most like fresh, vegetables. So I would say, yeah, some just like less processed foods. You do not need at this stage to be particularly restricted. You don't have to like reduce, absolutely like potassium or phosphorus unless, those levels are elevated at that stage, but they shouldn't. I think at that stage is more like a clean diet. However, less on like processed. The kidneys can only like handle like so much load. So that's why when we talk about that, as the kidneys progress and you're more advanced, they just don't have the filtering capability that's why the restriction comes in. It's just the kidneys are working 24/7. At some point, they just can't handle the load. So to help them, you need to offload that. So the diet will help offload. As not in stage 3, but in more advanced, then you would hear reducing animal protein in general. I would say probably the healthiest diet for the kidneys, which very hard to follow, but it would be a plant-based protein, for protein at least. It really it's not that plant-based is better type of protein. It's just it offloads the kidneys from overworking. But that's more advanced. In stage 3, I would say, less processed in general.
Okay, that's good. We had a thank you. They just had a blood test and they'll be able to understand the results better. So that's great. How does polycystic kidneys damage kidney function? In this case, it seems hereditary. Is it the weight of the cyst?
Yes, no, that's right. I didn't go over that because it's a very specific, so this is typically, a familial, syndrome, hereditary, can damage the kidneys, very early on. I would say, yes, the weight of the cyst, the weight of the kidneys, the larger, the kidneys and more the cyst, has a worse, prognosis compared to a smaller kidney. I would say if, anybody has, either themselves or family history of polycystic, should be screened, should be followed with nephrology earlier on. You want a tighter blood pressure control very early on. When we say normal target, I didn't go over that, 130/80 blood pressure. In polycystic, you want even lower, 110/60. You really want the lower the pressure, the better. And hydration, we're talking 2-3 liters, of water a day. And there is a lot of new treatment for polycystic. It's not just anymore just blood pressure and hydration. There is specific treatment for it as well.
When we say vegetables, are cooked ones equally good as uncooked?
Yes, I don't know if necessarily one is better, but I would say definitely in more advanced kidney disease or people on dialysis, for example, that can't have potassium, I would say you can have potatoes, or you should boil the potato and remove the skin, because you take away basically the nutrients and what usually would have been the best part of the nutrient, but you need to take that away because the kidneys can't handle that. But I don't know if something is better than cooked or uncooked particularly. I haven't not really sure.
Okay, and then one last comment. FYI, Prolia injections for osteoporosis cannot be done unless kidney function is safe enough. So that's
right. So that's another thing. So that brings me just in the general category of medication. So I always say, you need to be your own advocate for medication. So if your kidney function is slightly reduced, every time you get new medications, antibiotics specifically, a lot of medication need to be adjusted. Diabetes medication need to be adjusted for your kidney function. It doesn't mean you get less, but any other medication, even just general medication need to be adjusted, because when your kidney function is reduced, certain medications are cleared, through the kidney. Some medications are cleared through the liver, but also some medications are cleared through the kidneys. So the dosing, even though it looks like you're taking less of a medication, it's still the same effect as taking a full dose. It's just because, the kidneys don't work as well.
okay, fabulous. I'm not seeing any other questions popping in, just a lot of thank yous. So yeah, so thank you, Dr. Soussan. Thank you, Karen Wolfrat and Stony Brook Southampton. And of course, thank you to all the East End public libraries. And yeah, I guess that's it. So everyone have
thank you very much for your time. So we're here to help. We at least in our group, there's 3 of us, and we go, like you said, from West Hampton to Southampton. So we really serve the East the East End, not all the way end, but I do have people commuting from Montauk. That's a hard one. Yes.
That's a little far for sure, but very important. Yeah.
Thank you very much, everybody. Thank you, Dr. Soussan. Have a good rest of the summer.
All right.
Thank you so much.
Thanks, everyone.
Bye-bye.
Have a good afternoon.